on spec, but got no contracts. So capital has been invested and they have no revenue possibilities. And those possibilities have dried up even more since COVID we think is dwindling and mask mandates have ended. So that seemed to be a big problem. I mean, the other thing with this is that obviously in some SKUs, not all, in some SKUs, price competitiveness is an issue. And obviously, you know, health providers anyway, being bound by public procurement legislation, sometimes are challenged, you know, definitely when there's differences in price to go with a higher price. And then the other thing that came up, and no one take this the wrong way, especially the GPOs, don't take it the wrong way, is that they found it was a barrier to entry because of the contracts on some of the SKUs with the GPOs are so long. And we were talking specifically around respirators. Those contracts apparently don't open up until 2028. So, you know, so those three challenges, not insurmountable. So we thought that if we separated the SKUs a little bit and maybe came at it in a multi-pronged approach. So is it possible to get at maybe the respirators, because there was, and those SKUs in particular was a heavy investment by the private sector who retooled to get into those areas. Is it possible somehow that we could, because if you looked at it on I guess in principle, they don't have the issue with price competitives because the product is competitive to the others, the international suppliers. But the issue they have there is we don't have a contract. And so the solution would be, is it possible for somehow for the GPOs to open up? And maybe in this case, because respirators, the nature of it, maybe we could convince the feds that this is a measure, you know, a measure of protecting national security by granting some sort of an allotment. Then on the other SKUs, which, you know, the surgical masks, the gowns, the gloves, and all that, we had thought that there could be a separate path as a solution to get at those. And I know personally, I know in Newfoundland, there are representatives who sit on a federal FPT committee that's looking at this sort of concept. And there's one thing about Newfoundland, you know, we're small, we're only 2% of the national population, but because of that, we can easily get on the FPT agenda. I've done it before. I've been able to get things on the FPT agenda because we have a link in through the Premier, right, and also the representatives. So if it is something, we could likely get this on the agenda if we had a position paper, right? We need a position paper to look at, you know, our capacity and our capability, where it's located, you know, what can be done at different parts of the country. But I do think if we did that and tried to get on the FPT agenda and to get at the other SKUs. So that's what we came up with. Anyone else, anybody else on our group? So that's all we have.
Thank you. Any questions for the domestic supplier worker? Yes.
I don't have a question, but another aspect that you might want to build into the paper is criticality, which is becoming kind of a big buzzword in supply chain right now, because you don't want to be spending your time on something that's not critical but easy. You want to make sure that you're going after the things that really count.
No, good point.
Lynn?
And I think that you need to be speaking to the GPOs to see whether they even have the ability to open up those contracts.
I'm seeing this over here, Lynn. I don't know what that means.
That has to be recognized. There'll be a breach of contract to do that.
Yeah. Sure, go ahead.
You don't, but I also want to kind of level set. Just because the GPO contract exists doesn't mean that you're going to get purchases.
No.
The marketing and the demand has to come from the purchaser.
We thought that as well, and that's what we said to Barry. I said, Barry, if somehow you could get on a GPO contract and you're price competitive, then you got to work your ass off to sell it, like everybody else. Right.
What we've been telling suppliers is find the niche, find the difference, and market that delta.
Yeah.
And what problem it solves, because that's the way it.
Yeah, no question. Good.
Thank you. Barry,
Welcome.
did you have a quick comment?
Yeah, I did. So we have 3 niches that we're focused on. So number one, we have a brand new CSA standard for respirators, which identifies two new easier breathing pathways, which would be of interest to health workers. We have new environmental products, so plant-based products and reusable products. Sure, yeah. Check. And so we have new SKUs that have not been on the contracts before. So reusable products and plant-based products. And I think that should be, well, those are the niches that we're really looking to get into. And then the third one really is the variety of sizes in particular. Because prior to our industry starting up, you basically got one adult size of one SKU of one respirator from one company, usually non-adjustable straps, and usually sized too large for most healthcare workers. So a study just came out a couple of weeks ago that showed 80% of healthcare workers are smaller faces than what's in the bivariate panel for the NIOSH N95 standard, which is what the respirator manufacturers have traditionally manufactured to. So we have more comfortable, easier breathing products that are sized smaller and in a variety of sizes, and then plant-based and environmental.
Thank you.
Thank you.
Christian, there you are. Supply chain, oh, he has a whole sheet. Wow, I think there's a prize for the most diligent. Christian, you might have won the prize.
So there is a prize, but the prize is for anybody who can actually decipher my writing.
Okay, well, we'll throw that in.
This is an unenviable position. Anytime you go after someone from Newfoundland, the charisma is hard to match. So it's so I know nothing about supply chains. I just kind of so I'll start with a confession. So it was a fascinating opportunity for me to listen to the people in the group, and we had a really nice representation from government, not-for-profit, private sector, and academia. And when you put all type A personalities sort of together, then I didn't even have to say anything. You could just kind of listen. So it worked fantastic. So we spent, I think, and please afterwards, the group can correct me on everything that I get wrong. As I always tell my students, probably half of what I tell you is wrong. I just don't know which half. So we reframed the terms of reference, and so this is sort of in no particular order, but we thought so we had sort of two terms of reference here, and we sort of reframed these into like 4.5 new terms of reference. So. The first term of reference that we propose is to examine innovative approaches to economic, social, and environmental sustainability. So the initial sort of term of reference here read like examine innovative approaches to mitigate risk and reduce the environmental impact of medical supplies. But sort of the consensus within the group was that that was a rather narrow way to look at things, and that the ability to mitigate environmental impact in a country as Canada is going to be, as large as Canada is going to be difficult. But you can shift that to a stewardship perspective, and then try to focus on sustainability and on sustainability, so 3 pillars: economic, social, and environmental sustainability. The second then term of reference, I guess, that we propose for our group would be a shift to an outcomes-based, service-oriented supply chain by building trust through visibility, traceability, and reciprocity. And then Natasha Singh made the points of that, for instance, traceability is something that's closely associated with patient safety. And so I think the logic sort of behind this was on the one hand, figure out what your outcomes are, rather than sort of always thinking about the inputs and the activities that you're engaged in. And then if you're trying to get to the outcomes without sort of government trying to do everything, that means you're going to need to develop a trust relationship with your suppliers, with your vendors, and with the people with whom you're going to be working with. And I think, I guess, as an addendum, then I'd add to that, trust, of course, isn't something that you can build overnight. So that means, I think, as part of the community of practice here, the opportunity to build trust and relationships among a bunch of sectors that were exchanging business cards on top of the rubble during the pandemic. There's a great story on that, by the way. I don't know how many of you were in Ottawa about 10 years ago when there was an earthquake, and Public Safety Canada and Treasury Board are across from each other on Laurier Street. And during the pandemic, everybody was told to evacuate the buildings, and they were each told to cross to the other side of the street. So, kid you not, okay? So the third term of reference, to design strategies to improve safety and reduce/mitigate risk in supply chain security by improving redundancy, business continuity, reliability, protection, and interoperability. So the effort here was to try to identify what are the metrics that you want to be able to measure in order to be able to improve confidence in terms of safety, reduce risk, and give people assurance of the security and integrity of the supply chain. The fourth term of reference is to establish an inventory to surge capacities and resources for supply chain. No, sorry, hang on. I'm gonna. So to establish an inventory to surge capacities and resources to optimize supply chains for agility and responsiveness. So I'll just send these in an email there afterwards. And then Colonel Singh brought up the important, I think, point that the military does, but I think very few other organizations have the sort of thinking to do, and not that the military does it particularly well, but the lessons learned, that sort of you capture the lessons learned and you be able to translate these into operations. And I mean, what the military does is translate these also onto ongoing operations, not just do the sort of after action reports. So I think maybe with the community of practice, if we can build sort of some lessons learned mechanism, and not just sort of for the past, but for how we're operating. So I think that, does anybody want to add something to that? Adrian,
Yeah, so that final piece, not just an inventory, but almost a repository of things that we can all offer each other to help. I think in simple terms, you need cold storage, I've got cold storage, but I need something you might have, but I don't know that you have it. It's almost a centralized repository that in reaction to an event, we can match our need to someone who already has that and is able to help. That makes some sense, is that?
Okay, I made that edit. Anyone else want to weigh in on anything that I didn't sort of quite capture? I'm a married man, so I know listening is not one of my strengths. So.
Goodness knows you're still in training.
So.
Thank you, Christian. Colleen, digital supply chain.
Okay, so Christian stole my opening, which is, what do I know about supply chain? But in fact, Colonel Singh also pointed out to me that I am a pharmacist and therefore I know a lot about supply chain. However, what do I know about the digital supply chain? So we said the words, terms of reference, and then moved on. So we didn't quite do a belly button search of that because we kind of agreed with them, I think, from our discussion, which is identify priorities and strategy to strengthen data standards and interoperable supply chain digital infrastructure that is accessible and connects across jurisdictions. I think our language around that was way more colorful than what I've just said. But we had a good discussion. We talked about challenges and opportunities, and I'm kind of like an appreciative inquiry person that likes a positive core and what's working and what can we learn from that. But we did follow the text, and we did talk about challenges, and with lots of examples, which is really, really important. Because for me, the day is all about the possibility to leverage, right? As Colonel Singh has also said, we have 14 healthcare systems, and we have to start to be able to leverage the strengths of those. So the challenges actually that are somewhat ranked, our data flow is really hindered by not having standards. It's just hands down, that's kind of where we need to go, because really vendors can be, you know, the tail wagging the dog if we don't have those, right? We're kind of open to not being able to be interoperable unless we have those standards and hold people to them. So that's a challenge, but also an opportunity to work on that. The second one was goes back to that idea that maybe we should provide services, we should provide digital supply chain based on need, and looking critically at who actually is going to be using the data that comes out of the data flow. Otherwise, we're wasting a lot of resources in not concentrating on that. So that was the second challenge, was understanding provider side consumption. And I mean, Nancy used the idea that it's the glue that holds the system together. Glue gets a little sticky in digital technologies, but it really is, and we need to figure out how those things connect, and then how we can plumb them for their learnings, and not waste our time doing things that we don't need to do. I mean, how many of you have bought systems that have all bells and whistles, and you don't use, you might use 5% of them, 10% of them? Like, that's just a waste of resources. It's kind of like a pie in the sky. So the third challenge is that we haven't really defined our outcomes, either in a supply chain perspective or financial outcomes, even consumption data, etc. And it's like, so I'm a health services researcher by training and experience. Donna Beatty and structure, process, outcome. We always seem to get stuck on process. So we measure a lot of things about process, and who cares? We're way more interested in if we're getting to where we're going. So that was another challenge, was figuring out what those outcomes are. And of course, the opportunities are a mirror of that. So working on data standards, defining outcomes better. And it's really important to define those clinical outcomes. I mean, we talked, I don't know if Tim came back. I don't see Tim, but JP told us about the Alberta, Nancy says 10 feet from the bed. We know everything up to 10 feet from the bed. But it's important that we do close that gap between, we know what's in the storeroom, but we don't know what the patient's actually receiving. So that doesn't have anything to do with data standards, but it does have to do with outcomes. So our opportunities are, back to our terms of reference, to work on data standards. And by working on data standards and the flow of data to the bedside, we will in fact have been able to understand if we're being effective. So, did I miss anything? Francois, did I miss anything? I had a small but very engaged group. Nancy, did I miss anything? And I can't ask Tim because he's not back yet, but everybody contributed. And again, I want to just emphasize that issue around leverage. I think, so this is just me talking, but I think today has showed me that I already thought there was lots of existing models in Canada where we've worked nationally across provinces, the drug shortage, that structure that was struck after a fire in 2012, was it, Angelique? 2012 in Sanofi? that, we started the drug standards the drug shortages. That works nationally. I was involved in drug scheduling, which is how drugs are sold in provinces. That works nationally. We figured it out. It takes a long time, but they're built and we still use those structures. So leveraging what we already know, I think, is a good objective for moving forward. That was my privilege as the chair of the group that I could say that. Anyway, thank you, everyone.
You took it off my conclusion list. Thank you. Okay, JP, your turn.
Thanks, Anne, and everybody else. So one of the reasons I picked to be number 4 is because I could probably stand here and say all of the above, and that would pretty much be the work of the sourcing and procurement and the stockpile community of practice. Because at the end of the day, everything that you talked about in the first 3 will have to be factored into the decisions we make as part of the community of practice or recommendations we make in terms of how sourcing and procurement can be improved and how do we manage stockpiles in the future. So with that, we did have a very engaged group and we did have some really good discussion points, which then I tried to summarize into some points for presenting to you over here. In terms of the terms of reference, I think, we didn't get into all of the details other than we tried to identify the challenges and priorities. What we felt was that as part of the working group, we would need representatives from each province and each procurement system across the country because it's so important for us to have them at the table. We also identified that we'd probably need somebody that has expertise in performance measurement because as we look at outcomes, we want to be able to make sure that those people are part and parcel of it. We also wanted to make sure that we had a good representation of vendor mix, small and large vendors, so that we can get perspective. Also recommended that probably look at someone from the private sector who has a lot of expertise in logistics. A case in point, could we entice an Amazon or a Walmart to participate? And there was a lot of talk about vendor-managed inventories and how successful they are. But we also understood that in healthcare data and demand is not linear. Right? In terms of our demand planning, you always have to factor for the unknown. And while linearity may be at about 70%, previously pre-COVID, maybe 80, 90%, I think we are probably at a point right now where it's really around 70%, maybe, saying it's a bit too high, right? On the pharmacy side, there's a lot of good examples of national collaboration, but we don't think that exists on the non-pharmaceutical supply chain side. It's still very voluntary. It is still very reactive. If I have a problem, I can phone someone and get a response, but we don't really have a forum whereby, a formal approach to actually looking at solutions for supply chain really doesn't exist. And one of the things we felt as a priority for us is to see if this can evolve into that, if you have the right level of representation. Group felt very strongly that we needed to have potentially representatives from the federal and provincial governments, if we could, entice them. Maybe, I think it was Ron who said he has a lot of contacts with the FPT group and the Fed, so maybe he only has one. Okay, there you go. So that might be another area for us to look at. The other thing that we looked at in terms of sort of some of the challenges that we need to address, there's a lot of discussion that, and I think Scott and others raised this, the whole issue of value versus cost, right? And how do you actually reconcile the two? So value-based versus cost, meaning the ability to track outcomes, and which would also mean the ability to track outcomes, including the voice of the citizen or the end user experience. So that can we assign value to all of it and look at it in a much more holistic sense, as opposed to just looking at it and saying, this widget costs 1 cent, so we should buy this, but by the way, it's going to break in 3 months and we'll have to buy it 4 times over, when you could have maybe spent 5 cents, had customer satisfaction, and maybe used it for a longer period of time. I guess it just goes back to what we do in the retail, right? When we go look for something to buy, we can either buy the lowest cost TV or you can get one, that is the highest cost, but you really have to assess value and say, is your eye actually going to decipher the color quality for a 4K as opposed to whatever else, maybe the next level up, right? So I think we just need to be cognizant of value. And so that was really good. It was great to have Don on the team because I think he brought some good perspective from the citizen perspective standpoint. The other one that we really looked at, and I think I've already spoken about, is this ability for us to not recreate work. So we talk about supply disruptions, we talk about all of the things happening. We're all looking for solutions for the same problems, right? But the problem is that we don't have a formal way to share. And so, while we are looking for a substitute for one product, somebody else is looking for the substitute for the same product. If we can pool that together, we're actually creating a really good critical mass for the vendor as well. And it could lead to a secondary contract that could, again, result in a market diversified supplier base. And I think those are some of the things that we want to look at. The last one is sort of one where if you want to do all of these things and everything else that was in the all of the above, the question really boils down to leadership in supply chain, right? And leadership in making changes that are strategic, can influence the direction of the organization, and has the ability to test some of the risk tolerance, right? Because by nature, healthcare organizations are risk averse. Right? We want to make sure that, we don't sole source too many things. We don't step out of the box. We're talking about the health pro contracts, for example, contract A versus contract B approach. Do we move? So I think a lot of those approaches in terms of how we contract, we actually have to look at it and say, and I know we have, somebody from our legal side here that, I've known her for a long time. But, is there ability for us to push that a little bit, right? And in that, see if there's some strategies that emerge that can support domestic suppliers, strategies that emerge that can support, how we use data, strategies for some of the other things that you've heard. So I think that really is what we wanted to focus on. And by getting this group together, we do want to create a baseline of what went well, what didn't go well, and how are you managing your stockpile today? What would you do differently? Taking all of that with the group and saying, here's how we think this can evolve. So that's really on the sourcing, procurement, and managing the stockpile. Thank you.
It's a really good thing we're tape recording everything so we don't have to write notes so quickly. So I'm reporting out on 2 work groups. One is the Workforce Sustainability Work Group. On the terms of reference for that one, it's very focused on identifying workforce sustainability strategies that enable or support the quality and safety of the work environment, because that's what it takes to keep our health workforce where they are in delivering care. But that's enabled by supply chain teams and their leadership and decision making. So it's not how are we going to solve workforce shortages, although if we could, I would. It's really much more tied to what can supply chain achieve to enable and support every clinician everywhere to deliver best and safest care, but also protecting them. So just keep that in mind in terms of a terms of reference. We covered the waterfront, mind you, of all the other workforce challenges. And for sure, one of the challenges is there is often the 2 schools of thought, actually. We need more. So let's call the Philippines and send them all over. Let's call wherever, right? There are others, though, many of our clinician leaders, one who joined us virtually today, Kathleen MacMillan, we're not utilizing the full scope of the expertise we have. Why aren't we? There's 1,000 reasons, but we need to look at how do we now talk about leverage, really look at better, different, smarter, maybe collaborative models of care delivery that open up and allow people to do what they do so well. So example of the nurse in the community, the home care nurse managing those minor illnesses so that you don't have to have someone get on 3 buses and take time off work to get that little guy to a primary care doc, for example. So underutilization of our workforce capacity, and one of the priorities to look at that are how do we rethink collaborative models and different collaborative models that maximize the very talented and one of the most, by the way, the most highly educated health workforce in the world. We're often tied for first place with Finland, but Canadians are heavily sought after. What are some of those solutions? Collective agreements, regulatory, legislative. Why is it one? I think it was somebody in our group, sorry, I forget now who. Why does a nurse license have to be reviewed and approved 13 times? 10 provinces and 3 territories if we all have a pretty standardized accredited university education system. Seems a little weird. So there's a whole sort of regulatory, perhaps legislative piece to zero in on what are those and how could those be optimized perhaps. Clinician engagement in supply chain, that was missing in the pandemic. There were a number of clinicians that I visibly remember the nurse on the YouTube video or I think she took a video of herself begging for PPE. She happened to also be one of the victims of that horrendous Nova Scotia mass killing. I'll never forget it. I can still see her face. There's some of these images just stick with me, sadly. But clinicians being at the table to bring that clinician perspective on those allocation decisions that every province jurisdiction had to make. If you're in a shortage of critical supplies, you've got to figure out how to make best use of them. But without the clinicians at the table, you lose that trust and confidence. So that connectivity between clinician engagement and leaders was a second area. Thirdly is much greater advancement in technology-enabled models of care. Like, there's an awful lot of things. I had a chief nurse, here's a good example. Chief nursing officer was pretty interested and thrilled with what she thought was a success. When her nurses in her digitally enabled so-called care environment had to chart where they put a patient's belongings when they admitted the patient, 52 clicks on the EMR. She was thrilled because she got it down to 33. And I'm like, 33? Like, I'm thinking 2, because if it's not 1 or 2, I'm writing it on my sleeve and showing it to somebody, and that's off you go. So the technology-enabled models of care are things like digital intelligence and optimizing and automating things nurses, clinicians do that aren't going to help that patient directly, but just take their time and actually increase burden as well. So I think, did I miss anything on the workforce work group? We covered a lot of ground, and I think I've tried to pull the key areas. It's no question, supply chain, and this is a connectivity that I've rarely seen published actually. Supply chain really matters in terms of your workforce sustainability. Digital also. There's some early studies coming out of Australia right now. A more digitally mature health organization has much higher retention rates of workforce. So lots of great opportunity there, and looking forward to great things there. Leadership and policy, same group, sort of combined. And you can start to see where some of these pieces link, right? Regulatory, legislative frameworks, of course, are a leadership policy piece, but they have a very direct influence on optimizing a workforce, right? So regulatory and legislative policy is one area of opportunity, priority perhaps, that really spans everything from preparedness. If you don't have any policies on how you're going to collaborate with preparedness, it's not likely to happen. Workforce, we've talked about that. Data. What's the policy frameworks around data and how it moves and where it moves and to whom and how that gets managed in all of the privacy security challenges we're all well aware of. Data strategy to inform decisions, particularly supply chain oriented decisions that enable the capacity of a healthcare system to be agile and respond and resilient. We sort of debated, is supply chain resilience, if you have that, maybe you don't need preparedness, but if you have resilience, then you've got much more, tools to work with in challenging times, especially those that are, uncertain. But unless you have those overarching policy frameworks that help the collaboration happen across the jurisdictions teams, in many provinces within jurisdiction. Ontario was really challenged declared the pandemic 14 days after they appointed the CEO of the new Ontario Health Organization, when there was no longer LHINs and 5 regions that hadn't met each other yet. So, I mean, imagine how the challenges there, but a data strategy to inform decisions that gets you to that much more equity-oriented, focused decision-making rather than do the best you can with what you know at the time, right? Cross-jurisdictional collaboration. If ever there was a lesson learned in the pandemic, the 7 case studies that Adele and I and others, Colleen, worked on, there was the only collaboration we could find was if somebody knew a friend somewhere else in which they'd pick up a phone. And that happened with right through the whole system. There were clinicians whose, my brother's a surgeon, one of his residents worked in Spain, so we called Spain to say, hey, what's it looking like? How is it working? You know, what's working, what's not? So the informal collaboration happened, to many people's credit. Formalizing that cross-jurisdiction collaboration, building it into that pandemic preparedness type of framework that gets revisited. Because we did have them, Lynn pointed out to me, after SARS. Ontario had one. We even had a stockpile. Where was it when we needed it? It was locked under some key in some file, never to be seen or heard from again. So it's the revisiting, the refreshing, the updating, and the making sure it's going to work for all of those people in those current positions at the time, because we know people and jurisdictions and priorities all change. Did I miss anything on leadership and policy? So there are lots of options there. And what strikes me, as I've heard from each of the work groups, actually, is tremendous synergies. So at this very early stage, this is year 1 of this community of practice, and the outcomes and goal of the year 1 is create that community of practice. Bring these partners together, start to identify where those opportunities are and how we now go about engaging them and advancing them and achieving what I think we are all, it's pretty clear that there are lots of great options that we can achieve. This community of practice really, in my mind, creates a forum for learning. First, and that was clearly evident today. You could just some of the things people said was, wow, I didn't even think of that. So that forum for learning is critical, but that forum for learning now drives action. So if it's Ron Johnson that's going to get us to the FPT table, or any of those other influential decision-making, or our PHAC partners that's going to get us on the 3 Amigos agenda, for example. You and I talked about that last night. That's what this community practice is really about. And there's no assumption that we will just, write the playbook, hand the playbook to all the teams across the country and say, off you go, be happy. That's actually not what it's about. It's very much that co-design and really advancing the strategic role that supply chain has to play and did play in this pandemic, but not losing those lessons learned. I was a chief nursing officer during SARS. Nobody even knew what we'd already gone through and already figured out. Remember, I thought of that so often. I thought, oh, come on. Didn't somebody write this down from before? And the answer is we didn't. The other thing about supply chain, and I think JP pointed this out so eloquently, this is about partnership and trust. So very much threaded through this community of practice is partnership and growing and evolving those partnerships. Many of us have never been in a room together. And that, for me, is really one of the greatest opportunities, but building that trust, it's not assumed. We do and are very committed to working very hard at that to move this forward, because it's when you put together a group of such committed, talented, and insightful individuals, that's when things really do happen and we're able to really move the needle. I think the strategic focus on outcomes can't be understated. This is a country of health systems, but by the way, I've been doing a lot of research with other countries, Europe, US, Australia, Indonesia, Korea. No one's measuring outcomes. So why not Canada lead that particular opportunity? And without outcomes, then I don't think we are going to achieve the trust and the confidence of our citizens. And and of course, transparency that comes with that. Deciding on what those outcomes are is a whole different $1 million question. And in my mind, the outcomes that make most sense and are most relevant, and we heard from our equity panel today, is what outcomes are important and meaningful to whom, and who gets to decide. And that really, Adele raised this earlier on, shifting from the one size fits all, just here's your clinical pathway, do what I tell you to do and off you go, be happy, to what is it you want to achieve and how do we help you get there. That's just as central a supply chain issue for me as it is a health system almost mandate that I think we have the opportunity to influence. Leveraging strengths. There are a tremendous number of strengths. We tend to talk a lot about what didn't go well and some of the difficult outcomes, but I don't know, in my mind, never waste a crisis. The worst thing we could do is talk about what didn't go well and then and not change anything. So for me, it is leverage the strengths, figure out what the strengths are and where the strengths can be, and then build those strengths and those relationships, trust and partnership across all of the many jurisdictions we need to really action them, and build them into the DNA of the system, so long after all of us are gone, it's still there. And we've seen that happen. It has been done, like Colleen just talked about, that the drug shortages, that still exists and we rely on it very heavily. It's a group of people that just rolled up their sleeves and got it done. So I'm extremely excited about the opportunity we all have in front of us. And these are the kinds of opportunities I think every leader in this country is desperate for. I've been interviewed 100 times. I've met with many. They are looking for those answers because they don't have them, and it should come from those of us that are right in the midst of it all. That I think that's really our great opportunity. Why not define it with our leadership rather than waiting? We so often wait for others to do it, make those decisions for us, and then we think, oh, that's not a good idea. Well, if you're not at the table, you're on the menu, as they say, right? So, sorry, sorry, it seems to be the way it is. So just to wrap up, let me extend on behalf of the Scan Health team, our thanks for every one of you taking your time. We know how busy you are, how many other demands on your time and the resources and energy it takes to get here. And we are ever so grateful that you joined us. And we look forward to many more of these great, insightful, thought-provoking dialogues and work group activities as we move forward. You will have a copy of all the slide decks from today so that you can reference those, share them. When we have a chance and the group sort of debriefs and we look at all the many incredible outputs of our dialogue forum today, and each of the work group leaders, we're going to be looking at what partners are not here. There are many that couldn't come today, which is, of course, the way it often is. But making sure we do have everyone possible at that table. So we will be looking and reaching out to you to help us. Who else should we have at these tables? Some have been mentioned already. Who are we missing? Because if we don't have all of those perspectives, then we may not achieve our very aspirational goals. You all got USBs in the little credit card cool thing. All of the program and today's events and some of the background materials are loaded on that USB. So you'll have a resource to work from. That's a place to start. We'll often add to that. Any of you that have key documents or frameworks or references that you would say, you got to look at this. This could really help a number of work groups. Please send them to us. We're really trying to mobilize where are all of the strategic assets we should be informed by and working from as we go forward. We are also incredibly grateful for your feedback. How do we improve? How do we add? How do we strengthen? Because that is, this is the first time I've never built a community practice before. I had to look up what it was when the grant call came out. But when I did, it seemed like, well, this is a pretty good fit. We need to really think about how we can leverage that to achieve some important things in health supply chain. A special thanks to Laura Kilcrease and Tim Murphy. Yes, you did come. For Alberta Innovates, for hosting us today. It's been phenomenal. The food was delicious, by the way. Thank you. And that was just in the spirit of being an incredible partner. Laura was already thinking about some other events and activities Alberta Innovates is doing. that we can perhaps leverage and have another gathering. Your team, Katie, Vincent, and Kelvin, were amazing. Scan Health is a very small team. Zena, my MBA students, Catherine, where's Catherine? Catherine, Lori Turk, who's missing. That's the entire team who worked absolutely tirelessly, and I just wouldn't even have attempted this without them. So special thanks for their hard work. GS1, Canada Shoppers Drug Mart, sponsorship support was amazing. So very grateful for that. And it really did just make it possible. And our speakers today and our work group leaders, you know, they're unbelievable. Colonel Singh is bringing the whole military perspective that I knew nothing about, and I'm so grateful for. I should just go across the room because you've all brought such incredible expertise. JP, that opening keynote, I think I'm going to have to write a paper on that transcript, get you to proof it for me, because everybody's got to hear that story. It was amazing. Ron Johnson, Newfoundland, you can't have any successful strategy without a Newfoundlander. I don't know. It's just incredible lens and perspective. Angelique Berg, Colonel Singh, I think I mentioned. Scott McNair, BC, helping us figure that out. How does PHSA work and how do we learn from PHSA? I'm hoping Ontario takes a few hints on that. Matthew Foss, he had to leave early. I'm so grateful for that Indigenous perspective and lens, both for the Aboriginal-led businesses and with Bonnie Healy. My secret, she isn't aware yet, and I'm really hoping to drag her into this community of practice and perhaps any others, because it becomes so critical. If you are serious about equity, that's a perspective. I had no idea the Blackfoot way of thinking and Maslow hierarchy of needs. Anybody else know that? I mean, Maslow I studied, I hate to say, half a century ago. Work group leaders have been phenomenal. They've been meeting behind the scenes just to get us to this point, and I can't thank them enough. Again, JP, Ron, Colleen, Medge, Christian. Kathleen MacMillan couldn't join us. She's digging out of that storm in PEI. Couldn't, move the trees quickly enough off the roads to get here. And Susan Moffat-Bruce, who's the CEO of the Royal College of Physicians and Surgeons, had a family emergency. She was to be here, but just couldn't get here. And on the domestic supplier work group, Jay Myers is working with Ron. He leads NGen, the manufacturing supercluster, and has worked closely with many of the Canadian manufacturers over the case. So thank you. Thank you to our team, Hazina and Catherine, under pretty interesting circumstances when team members were dropping like flies on our way, for your incredible hard work late into the night. Very much can't wait to work with all of you. And again, if you have thoughts, ideas where we could do more, do differently, reach out to very key stakeholders. Please let us know. Special thanks to Lynn Golding. Lynn is on our board of directors. I cannot thank her enough for hanging in there and showing up and making sure we are on the straight and narrow. So that was not to be left off at all. So I wish you safe travels, and very much you'll be hearing from us. Not too much. We'll try not to load up your inboxes. But you'll be hearing from us soon about work groups coming together, starting down some of these areas of work and priority you've all identified. And follow-up dialogue forums and the when and the how. We're loosely planning spring as a next one to give the work groups a chance to come together and start down, see where they can get to in terms of establishing by the end of the year the plan, the go forward, the co-design, the who and the how and the what, essentially. So that's where we are. Absolute delight and pleasure to spend the day with you. I hope it's been something you found valuable and helpful, and lots of opportunity. And don't forget those, write them down, send us an email, and we will track down every one of them to be sure we don't lose any of the potential opportunities. So thank you again.